Maima. O te rā, tēnā koutou katoa. E mihi nui tēnei kia koutou, ko hona mai I tēnei pō, mō tēnei hui. Just a big mihi to everyone that's attending this hui tonight, and to embrace the karakia, to start our hui off on a good note. So I won't drag this on any longer, but we'll start off with our karakia. Tēnei tinihinihi, tēnei te tupua. Ia tauriro riro ana te whare o rongo e ruku. I herea ki reira te mana, te ihi, te wana me te tapu. Kātou pōkinga atu ki te pū, kātou pōkinga atu ki te wānanga. Kātou ko te kuratangitia, ia tau ki runga ki tēnei hui, kia tau ki runga ki e nei tāngata. Turu turu o whiti, kia whakamaua mai kia tīna, tīna. Haumi e hui e tā iki e. E mihi ana ki a koutou, ngā tūpuna e ngā atua, kia whakapiripiri mai rā kia mātou I tēnei huihuinga o mātou I tēnei pō. Kia arahina mātou I roto I te tika, I te pono, me te aroha, me te māramatanga. Kia taupōkinga atu ko te rongo, āwai te rongo, ko te rongo o tāne. O tāne te waiora, ko tāne whakapiripiri, ko tāne te wānanga. Tāne te waiora I tū wai, te tangata, I puta ai ki te whaiao, ki te ao mārama. Haumi e hui e tā iki e. E mihi ana kia tātou I tēnei pō. E mihi ana ki te kaupapa nei. He kaupapa nui, he kaupapa tapu. Me ki, e tangi tonu ana te ngākau, me ngā roimata kia rātou kua whiturangitia. Ngā hunga mate kei wanganui a koutou, me ki kā tangihia, kā mihia, kā poroporo a kitia. Ka whai whakaro ki a rātou te hunga mate kua whiturangitia. Nā rātou tēnei mahi I para I waiho mā mātou, hei whai mā mātou hei tūtuki. Nō reira, me ki ho rātou te hunga mate ki a rātou haere, haere, haere atu rā. Hoki mai ki a tātou te kanohi ora, tātou e hui hui nei I tēnei pō, tēnā koutou, tēnā tātou katoa. I just wanted to mihi to everyone today and to start off our karakia with a karakia, an old karakia, traditional Māori karakia, which is called a taku that we use in the name of rongo. Rongo is the atua of peace. Rongo is the atua of clarity. Rongo is the atua of balance, the balance of life and death. Rongo is the atua of cultivation, whether it be cultivating whakaaro ideas or whether it be cultivating food from the whenua. Within Te Ao Māori, the garden and the mind is the same thing. What you plant in your garden and what you water will prosper and will bring forth goodness to you and your whānau and your hapu and your iwi. And same with our garden and our mind and our whakaaro. What seeds you plant in your whakaaro and you water and nourish will bring forth whatever you planted in your mind. So rongo is the atua for the karakia that we use today and tonight for this kaupapa. Also, a mihi and acknowledgement to those that have passed on, those within your whānau, those within my whānau, those within our wider whānau and our wider community. And every day we acknowledge those that have passed on and the work they have left behind for us to finish, and also the legacy that they have left behind for us to follow in. So every day we acknowledge those that have passed on. And I use this word whiturangitia, which means to turn into a star. And the star is there to remind us of the balance of life and death. And the star is there in the sky to remind us that we are here on this realm, in this place, on this earth, and they are there. And they are the stars, and they are the reminder in the sky at night that there is light within the darkness. So rongo is also the holder of that, and also tāne. So I use tāne within our karaki as well. And tāne is the person who brought light into the darkness, and was also the person, the atua, the deity, the God within Te Ao Māori, who created who created hine ahuone, the physical being that we are today. Tāne created hine ahuone in a place called Kurawaka, and funny enough, in the Bible, that place is called Eden, and that place, some people say, is in a place called Ethiopia, where man was created, and the place there where they say is the Garden of Eden has a red clay that was also that we talk about in Kurawaka. Kura means red, waka, we know what a waka is, a vessel, a boat, and that waka I'm talking about is the flesh, our body. So there's no coincidence there. And so we acknowledge Tāne as well, because Tāne gave us life. Tāne separated rangi and papa, heaven and earth, for us to live in the middle, in the world of light, Te Ao Marama and Te Ao Māori. So mihi to everyone today, and mihi to this kaupapa and those that have organised this hui tonight, and those that have joined us also. A very important kaupapa to wānanga and hui about, especially when we as man, as tangata, hold that balance between life and death. So we just mihi to everyone, and also to you, Hamaima, for allowing me to be a part of this hui, and also everyone else that has been involved in organising this hui tonight. Mihi ana kia koutou katoa, tēnā koutou katoa.
Tēnā koe, Rupata, me mihi nui kia koe mo tō karakia ki te āwhina i a mātou i tēnei pō. Thank you for your karakia, and thank you for your words of wisdom. And there may be many of us online tonight who may not recognise the symbols that Rupata has laid out for us tonight, but our kaupapa around End of Life Choice Act is actually grounded by many of the things that Rupata has presented this evening. So tēnā koe Rupata, mihi nui kia koe, tēnā koe, and tēnā koutou katoa. So we are so pleased to have those of you who are present this evening. And so we're going to get straight into our kōrero, and the kōrero that we've got is very clinically focused, and I'm hoping that at a different time we'll be, if not tonight, we'll be able to weave into our thinking some of the thoughts that Rupata has left for us this evening. So thank you. I'm going to share my slides, and we're going to begin our kōrero. And there will be time at the end. Graham and I will share the talking space, so you'll see us go backwards and forwards this evening. And then at the end, we will have a question and answer time. If you have any questions as things are popping up in your mind, please don't be afraid to use the chat. And Graham's very good at keeping up to speed with people's thinking, and he may be able to respond to you with a response fairly quickly. So let me share the screen, and let me share my screen, and then we will get going. Okay, can I just check that? Hang on a moment.
You need to go to the presentation view at the bottom, right?
Am I there?
No, yeah, now you're there.
Okay, cool. So you'll see just across the bottom of the beginning of the slides, everybody is going to receive this package of slides. And you'll be able to share these with other people. And you can see across the bottom, we've named those of us, the three of us who have been working on this presentation. And at the end of the resource, there is also a list of resources and websites that you can refer to. So that will be useful to you in the end. You will no doubt recall that you received a survey. We sent out a survey monkey, and this was to help us understand the degree to which people were aware that the Act was coming into play. And we also wanted to understand what people's awareness about what was available to support them in the implementation of the Act. So you can see throughout these several pie graphs that you can see, all the blues represent yes and the oranges are no. So the first one in the top left-hand corner around those who were aware, that there were a lot of people who knew that this is coming into play on the 7th of November. But as we can see as we go along, the awareness of where you find the information is probably not quite so clear, and hopefully it'll be clear by the end of this evening. And do you feel prepared and well informed? We had 22% of the respondents say yes. And we did ask a question around how comfortable people felt about discussing this with patients. And so we out of the small number of people who responded to this particular question, this is how we fared. So we recognize that probably, you know, there's a lot to be spoken about and have discussions and support so that people feel comfortable in this very sensitive conversation. We did ask the question about how many people thought that they might need ongoing support from mahitahi. It's really important for you to know that mahitahi hauora are here to support and hold the space for training around knowledge and skills and competency. And so that is the role that we're playing at this particular time. And we'll continue to do that until people feel like they're confident enough with this piece of work. And we also asked the question about how many people felt that they would consider having an active involvement in this therapeutic process. So there were 41% who said yes. And so this is hopeful that we will all recognise that regardless of whether or not we are conscientious objectors in this process, this therapeutic process, that we will all feel have an awareness about how we fit into the conversation. Graham, did you have anything you wanted to add?
We haven't got a large enough sample yet to draw any meaningful idea about the level of provider answer to those questions. So as hopefully we get a few more answers, then we might be able to get a reasonable sample size to understand the different roles of people who've answered the question. So we can't draw conclusions from that data at the moment that that's a group of individuals who would actively engage in the process or not, because a number of the responses are from people who will not meet the legislative requirement, but obviously would still be involved in having a conversation. So thanks.
Thank you. Kapai. Okay, so getting into the kaupapa, just outlining assisted dying is a really sensitive topic. It is really important that we seek support from our colleagues and other peer networks and people from your other professional organisation, GPs and nurses and health assistants. Whatever role you're playing in is important to recognise where you can get support from. And EAP is also raised as a point of emotional and psychological or mental health support if you feel as though you need to access that. So the delivery of assisted dying services, these comments represented on this slide are really laying out that the process of assisted dying is a publicly funded therapeutic process. And so through the SCENS group and as a result of the legislation, public funding can be sought to support how the process goes. Eligibility. So there's some really specific things that people need to fit into an eligibility criteria. These namely being that you need to be 18, a citizen or permanent resident, have a terminal illness, that your life is going to likely to end within 6 months, that your illness is in an advanced state or irreversible decline in physical capability, and experiences are unbearable, that there is unbearable suffering and cannot be relieved in a manner that's considered to be tolerable. And most of all, it's really important that the person is competent to make informed decisions about assisted dying. And a person is not able to receive assisted dying solely because they are suffering from a mental health issue, or have a disability, or are of an advanced age. So a combination of all the eligibility criteria as above is important. It is really important that the person themselves, for whom this is involving, needs to raise the question about assisted dying first, not the health practitioner. A whānau member is not able to raise the topic, and if asked regarding end-of-life options, the health practitioner can discuss palliative treatment options only. So there's, we can, as a health professional, we are able to support people in many ways, and palliative care is one way. And as we go through the presentation, you'll see all the other different ways that we can help.
So we'll talk more specifically about this, but particularly in terms of health and disability legislation or guidelines, and this legislation have got some very specific points that we'll raise later on. But just, you can, unless the patient raises the issue, you can't introduce it as one of the end of life options until they do so themselves, which is fairly contrary to health and disabilities approach to informed consent. And we talk to that more specifically later.
Yeah, cool. It is really important that when we're starting the conversation, health professionals take time to reflect upon this really important topic, and that they are able to consider that we can consider what our own views are about assisted dying, and reflect on how those views might impact, and on how they would and how you might respond when assisted dying is raised. We're here to build knowledge, so it's important that we ourselves know the facts about the Act, including our role and responsibilities, and understand the criteria quite well, and know what the organisation's policy is. So as organisations, in whatever areas that we're working in, it's important that our teams have had an opportunity to think about what our position is. It's important in terms of confidence that health professionals can practice responding, and that in your team you know how to support each other. Assisted dying conversations need to be culturally safe. So we do have to think about what does culturally safe mean, and how do we support other people who have come from different cultures. I think that's about all for that. There'll be other things as we go along in this conversation. So when we think about roles, the roles of whānau, it's really important that only the person themselves can ask, only the person themselves can ask the question about assisted dying. The whānau are not able to make that decision on the person's behalf. And that's a really significant part to recognise, because part of the eligibility and part of affirming somebody's competence is to check that there is no coercion in the decision making. So if we now let's have a look. So there are specific roles outlined in the Act. So who can determine a person's eligibility for an assisted death? So we call the person's eligibility must be determined by 2 medical practitioners, and the person needs to be found eligible by both in order to proceed. If the competence is not established, then a third opinion, which may be sought by a psychiatrist, may help to resolve that eligibility. And the third important role is establishing who can administer the assisted dying medication. So this can be administered by either the attending medical practitioner or an independent medical practitioner, which might be a nurse, or it could be administered by themselves. Graham, did you want to add anything here?
I think you expand on this in the next slide. Yeah, so
statutory bodies and roles. The SKINS group is, and now that I'm here, Graham, what's the SKINS group? I don't know.
So the SKINS group is, it'll be translated. The words are long and complex, but that will be in one of the other slides. But basically a statutory body appointed by the Director General, and their main role is to maintain a list of practitioners who are registered to offer and deliver the service as requested by the whānau or the patient. You don't have to be involved with scans, and they hold the knowledge, and that knowledge of who is available is going to be closely protected by the SKINS group. They are managing the standards of care. They provide advice on the legal and specific medical procedures, and they will have, my understanding, there are going to be 2 health navigators or health coaches who are aligned with the SKINS group, who will be resources available to both patients and providers in situations where there may be some clarity required. The registrar is a Ministry of Health employee and really the linchpin in facilitating the process, ensuring that it is a quality service and all the legislative requirements are met. There's a number of documentation that has to be undergone. They have to review the various reports. They report to the minister. They have a role on mediating if there are concerns or complaints. And then they're an instrument of the review committee. And then obviously there's an overall quality control process that's managed by the review committee. Thanks, Amama.
Thank you, Graham. Let's just go to the next one. Okay, so the Secretariat, the Ministry of Health has an assisted dying secretariat that supports the assisted dying pathway and provides a consistent point for contact for the person, their whānau and health practitioners. So there's the backup if anyone is in need of support and clarification, the Secretariat is available there for that purpose. So they can provide support and advice to practitioners, and also includes clinical advisors who provide information. And the registrar is a part of the Secretariat, and that is a statutory role under the Act.
So Jemima, what people need to recognise is, you know, if you're a conscientious objector or you have other reason why you're not engaged in the process, and there's some navigation or some connections needing to be made, then we are not left totally on our own devices to scrabble around and find the right connections. The Secretariat is there to be contacted and to help in this journey to make it as cohesive and functional as possible. So, you know, we often find ourselves as practitioners wondering what's the next step, where to next. To have this level of support in the background gives us confidence that the aspirations of the individual patient will be met in a timely and efficient manner by the right person at the right time.
Cool. Thank you. Okay, so here are the roles within the pathway. We've got 5 particular roles. You can see at the beginning, we need to have 2 people who provide the eligibility competence opinion. So we use an attending medical practitioner, and they are also responsible for preparing and administering the medication. The second person is also a medical practitioner and could be an independent person to provide the second eligibility opinion. And in the case where there may be some disagreement, a third person or psychiatrist may be involved to help with resolving any competence issues. And the fourth person may be an attending nurse who may also be involved in delivering medication. And the fifth person will be the pharmacist who will dispense the medication.
So, Jemima, again, it's really important that it's clear that if the patient attends you as a medical practitioner and instigates the conversation, that you are by default the attending medical practitioner, unless you immediately are informing the patient that you have a conscientious objection, or that you are not trained and don't have the competence to assist them in that regard. And those are the only 2 ways that you obviate your responsibility as an attending medical practitioner. So it's got to be upfront and very early in the conversation to not take on that responsibility. So there's formal training that has to be undergone, one, to learn how to actually deliver the service, and to obtain the Section 88 funding. If you haven't undergone the formal training program that the Secretariat and the Ministry have set up, then you're not able to deliver the service. And the other thing is that the nurse practitioner can only join the process at level 4, so they are not able to be an attending medical practitioner or an independent medical practitioner. Thanks.
Oh, thank you, Graham. Thanks for that clarification. All right, so let's just have a look at the process and see how it's going. I've put together a slide that shows how things flow from one point to the next. So in the beginning, there is, I'll just go back. In the beginning, there's a request is made to an attending medical practitioner. Section 11 is engaged, and we'll talk about the details of Section 11 shortly. The request is confirmed, and then there is an eligibility competence opinion is made, and then a second eligibility competence opinion. If there is disagreement, as we've mentioned before, psychiatrists can be involved, following which, all going okay for the patient, an agreement, date and time can be established, and an arrangement for administration of medication. Then a prescription is made, final approval and indication to the registrar. Then the medication can be administered at the date and time established with the patient. And then, of course, we've got an end point, which finishes with the report of the death. So that is quite an involved process. There are lots of little pieces in it, but that's the flow. That's how the flow of it goes. So important to note that the person can withdraw from the process at any time, and if the person is not eligible, if it is decided at any point in the process that the person is not eligible, then the process must be stopped. And the medical or nurse practitioner must also stop the process if they have a sense that coercion is suspected. Participating in the process. If you want to participate in the process, I needed to clarify, Graham, can you? You need to be on the list of health practitioners who are willing to provide assisted dying services.
So,
and the is held securely by the schemes group.
Yeah, so we got some clarification on this. There's no specific register for conscientious objection. You just have to declare it. You can register your interest with this schemes group as someone who wants to actively participate and deliver the service, but you don't have to be a member of SCENS. You can choose to deliver that service independently as long as you're trained to your own enrolled population. So you can choose to undergo the training, offer it to your enrolled population, but not register with SCENS and therefore not be called upon by SCENS to deliver the service to patients who may not have a relationship with you or not enrolled in your practice and therefore be a default provider for other people. So it's only if you've registered with SCENS that you will be contacted to be involved in the service. They will hold that list of known registered individuals, and therefore they can allocate a AMP or independent medical practitioner if the patient's own provider is a conscientious objector or hasn't got the training and competence.
Thank you, Graham. This next slide sort of covers exactly what you've said again, and we've mentioned earlier as a part of the process. So there are other ways to be involved in the process. Outside of the process, health professionals can participate in conversations with the person. You can discuss appointments, you can provide expertise and direct people to more information. You can help people with and whanau making more practical arrangements, such as deciding where the assisted death may take place. Being present and providing support to the person in the whanau is also a really important aspect of this process. Graham, did you want to talk a little bit about the place? Because we know that we're expecting that more people will access support for assisted dying to take place at home, but there may be other opportunities or other venues have been discussed. Do you want to add to that?
Yeah, so I mean, the evidence from overseas is the majority of people would choose their home as the venue. Obviously becomes more complex in rest home level care, and these are some of the dilemmas that rest home are having to work through at the moment. Of, do they as an institution have a conscientious objection and therefore aren't going to offer the service for their residents, yet they are the residents' home, and if they conscientious object as an organisation, are going to have processes and policies in place that support that person to still achieve their chosen therapeutic intervention, and therefore have provision for patients to be seen or managed elsewhere, either in family home or if there are other institutions where they can transfer them. Obviously, the hospital is the last place that we would want that to occur by necessarily, but by default, the hospital is obliged to assist in the situation where there are no other venues available. And we're working closely with the hospital, and the hospital is well aware of the legislation and ensuring that this service is available and safe, but is not the venue of choice.
Thank you. The next few slides talk about conscientious objection, which Graham has already raised. So it's really important to know how to make your conscientious objection known to the person that you're supporting. So regardless of our own personal beliefs as health professionals, we still have a professional responsibility to not inhibit a person's access to lawful medical treatment, and we are responsible for ensuring continuity of care is maintained for them during this experience. Is there any, I've skipped a slide because this slide here talks more about the way in which you may want to respond if you have a conscientious objection. It is important that you establish that and tell the person that they have a right to ask for support, and you can direct them to that support, to the SCENS group, and they have a right to access the contact details of a medical practitioner who may be able to support them in that process. Is there, do you want to add something to that, Graham? I know you've got I think we've talked about it earlier. Do we need to cover it again?
No, just box on.
Okay, great. So under section 11, these are the things that an attending medical practitioner needs to do. Must be able to give a prognosis and information about assisted dying, stay in touch with the person the whole way through the process, ensure that they understand their end of life options, ensure that the person knows that they are able to change their mind at any time, and encourage the person to have their wishes met by working with their families, though they are not obliged to do this. And we're also required to ensure that the person has an opportunity to discuss their wishes with whomever they want to. Also, we need to ensure that the best, I've just said that, that the person is able to experience fully the things that they desire for themselves as they're working towards this end, and the doctor also must record the actions that are taken as they come up in the care plan and through the discussions with the family and this, in particular, the person that they're working with. We've got a little example now. This example appears on the online learning module through the ministry. And this example demonstrates how you might apply the principles of the Act as we have been laying them out this evening. So this is a little narrative about a patient, and his name is Royal, and he has stage 4 lung cancer, and it's steadily going worse. So he goes to visit his doctor, and he, while he's there seeking more support, more medication support, he poses the question about whether or not he is eligible for assisted dying. So there he is making his request, and then Dr. Turner takes a moment to explain that he has a conscientious objection, but this doesn't preclude Royal from having his wishes addressed. And so it is the responsibility of Dr. Turner and others who come into this picture to support the patient. And he does this by helping Royal to contact SCENS and find a suitable medical practitioner to help him.
So, Maima, in this example, it talks about Dr. Turner using the conversation guide to help support the conversation on the Ministry of Health web page around end-of-life care. There are significant resources that are available to assist both those registered and those who are having the conversation in managing these conversations. A really good conversation guide with some good examples, and also a number of webinars. The first webinar that's available through the e-learning site is 2 doctors who have been actively engaged in delivering the service, one in Canada who now works in Nelson in the South Island, and the other a oncologist who works in Victoria, Australia. And that webinar touches a lot on the kind of conversations and how those conversations might be handled. So it's really a worthwhile visit to those webinars and to actually look at this conversation guide. A lot of work has gone into, making it simple, and for general practitioners, actually not a bad resource to manage your day-to-day patient conversations in any context. So it's really a useful resource. Thanks, Amama.
Thank you. Awesome. So around the care pathways, there are three main pathways. So we have medical practitioners who do not provide assisted dying, health professionals who cannot provide assisted dying, and then medical and nurse practitioners who will provide. And so it's really important for us to understand where we might fit into this pathway, because everybody still has a role to play. So let's just have a quick look at that. So in the pathway, first of all, there's the application and the first opinion on eligibility, an independent assessment of eligibility. So there's the first one, and then the second one around competency if this is needed. We've muddled that up a little bit. And the third one, if there is disagreement and resolution needs to be supported. Then there is a firm decision made on the eligibility, and this goes forward to establish a prescription and administration of medication. So a care pathway for medical and nurse practitioners providing assisted dying services. So assisted dying is one option for the end of life care. It is not a replacement for healthcare services, which includes palliative care. These still can happen. Most people on the assisted dying pathways will also be accessing other healthcare services. So this is a really good time for a wraparound and extending other supports that might be available already in the community. So whānau support, it's really important if the person, we should be encouraging the person to involve their whānau. That may not be their choice, but if they can, that would be a really good thing to do. And most people will do that. Some people may choose not to. If whānau are involved in the person's pathway, they can support the person with care, planning, transport to appointments, making arrangements, recording information, and helping the person through their experience. So safeguards for the Act and understanding options. As part of their conversations with the person, a medical practitioner must ensure that the person understands their options for end-of-life care. This is a really important part of ensuring that their decision for assisted dying is an informed choice. So at this point, we just want to tie into this process to tiriti o waitangi. So recognising that the principles of the treaty include tino rangatiratanga, which is the ability to make decisions and to act upon those decisions with the most amount of support, with whānau, with clinical services on board. When we think about partnership, this is walking down a road, walking through a journey with other people who are working in partnership with the choices that they make. We do this by being able to map out the choices that are available and helping people to be informed about what each of those choices mean. And active protection means to support and help patients through their particular experiences, providing them with all of the information that helps to protect them against any harm. So when we think about what is happening to them, we want to make sure that no harm comes to them as a result of any choices that other people make in this in the process. And equity, of course, is the ability to support people to access the choices that they need and help them through some of the barriers that might pop up through the process.
So, Jemima, you mentioned harms, and one of the conversations that comes up is that our medical principles are first, do no harm, and so questions have been raised about, isn't assisted dying a harm? And when you listen to the webinar with these other two doctors, the point they make is that by ignoring the patient's informed decision and wishes to follow a therapeutic intervention is harm in itself. So, not respecting a person's wishes or not facilitating their choice is equably a harm as to do something that's maybe physically harming them by your poor actions, for example. So, these are raising quite significant ethical questions that, as you've raised before, people really need to have taken some time to think through themselves. What is their standpoint? What is their current journey of and understanding of what constitutes healthcare and how that might change in this environment where this legislation actually might run contrary to everything they may have been taught or learned or believe in as a medical principle up until this stage. Thanks.
Thank you. On the issue of competence, these four things that are represented on this slide: comprehension, the ability to recall, and memory, having the ability to reason, weigh up relevant information to make an informed decision, and be able to communicate their decisions. So these 4 things are what is being looked for when we're thinking about, is the person competent to make this decision? And this level of competence needs to be present right up until the medication is administered, or until the time of assisted death occurs. They must have this level of competency. So protection against coercion. The attending medical practitioner should speak to other health practitioners who help them to understand, who have had contact with the person, so they can understand the degree to which coercion may exist in this person's decision making, and be able to speak with the person's whānau, so that they can see how the person sits with the decision themselves.
So, Jemima, again, in the webinar with the 2 doctors, there's some really simple guidance on how you might approach the conversations with those around, or those who might help you make a decision about the presence or absence of coercion. So there are obviously various ways that you can explore open-ended questions, both to the person themselves, open-ended questions with the whānau, or, as you've pointed out, initiating conversations with other practitioners who may have been involved in their care, for example, the oncologists or the Cancer Society nurses who've had conversations with them. Thanks.
Cool. The next slide leads into, extends on the example that we started with Royal, to show how competence and eligibility in the decision-making process can happen. So in this example, following the confirmation of the request, the doctor reviews Royal's medical records, and he speaks to his specialist, who states that he expects Royal has a prognosis of around 3 months, and this confirms to Dr. Smith that Royal is indeed eligible for assisted dying. A second opinion is sought, and then there is the Secretariat connects with Royal with a suitable person to help him. So this person is Dr. Hedeny, and he goes through a little process that helps him to feel informed about Royal's decision, and then confirms that he agrees that Royal is eligible. So Dr. Smith then meets with Royal, and then they discuss the outcome of those 2 assessments, and then they begin to establish a date and a time. Was there anything to add, Graham? No.
No.
And then the attending medical practitioner, who is Dr. Smith, has travelled to Royal's home to meet with the whānau and talk about the plans that Royal made. And Royal has engaged his family so that they're all included. His children are there. His older daughter is taking the role of a spokesperson. Dr. Smith explains the medication method. He takes time to help the whānau understand the process, providing explanations, reminds the patient, reminds Royal and the family that the process can, that for Royal, making the decision can stop at any time. Detailed arrangements are made, and then Royal is left to think about those. He's given some space to think about it, and to think about the options that have been presented to him, and then Dr. Smith can come back and complete the appropriate forms and establish the confirmed date and time and the method of administration. So it's quite a detailed process, and all along the way you can see how important it is for Royal to demonstrate his competence in the decision making. There are 3 different stages of recording, 3 different recorded pieces of information that are important. Notifying the registrar, confirmation form needs to be signed and dated, and then the registrar needs to be noted. The registrar needs to notify the medical practitioner so that the process can then continue. So here in our example, Dr. Smith writes the prescription, and this prescription is written ahead of time, several days ahead of time, and 4 in this example. And this is because there needs to be time for the medication to be prescription to be dispensed by the special pharmacist, and in this case it would be with the DHB. Do you want to talk about that, Graham? That dispensing process? And
so there are only 2 DHB hospital pharmacies that are identified that are the source of the medication. So it's not a prescription to your local community pharmacy. So, having set a date and time with your patient, the last thing you want is a hiccup in delivery of medication that may be coming from a remote site. If you're living rural, and the pharmacy is based in Auckland, you don't want a courier delay to interfere with the process. And the other part of this is then, you make the decision. You cannot proceed till the registrar has ticked all the boxes and checked all the forms and made sure that eligibility is met and all the processes have been followed. So, you want to have left yourself a reasonable amount of time for all of those critical steps to be enabled. So just giving yourself a window of opportunity is probably sensible.
thank you. We've talked about this already, but it is so important that the person can choose to receive the medication at that time. They can choose to not receive the medication at that time and may want to wait and make another date. And they can choose to not receive the medication at all and rescind their request for the option of assisted dying. So all along the way, the person can be in control of making the decision or stopping the decision to proceed.
So, Jemima, important, it's probably not clear in that slide, but they can choose to delay it just on that day, for example, or choose to change the date and time. So choose another day and another time, but clearly that can't be deferred more than 6 month. Legislation doesn't allow that to continually be deferred beyond 6 months. After 6 months, the process has to start from scratch again, and the whole process has to be gone through again.
Cool. Thank you. So how does the introduction of assisted death affect my practice? And so these next few slides are around the Code of Health and Disability Services and Consumer Rights. So health practitioners should have their obligations under the code in mind, because these are going to, at some point, feel like they're a contradiction or might bring up some conflict. So, for example, assisted dying services need to be provided in a way that complies with Right 1.3, and this outlines that services should take into account the needs, values and beliefs of different cultures, religious, social and ethnic groups, including the needs and values and beliefs of Māori. It's also important to note that there are a few instances where the Act overrides parts of the code in relation to assisted dying. So a health practitioner cannot raise the issue of assisted death. So the health practitioner this overrides right 6, which states that a person would expect to receive an explanation of the options available. So this is why it's important for us to think through and prepare what might be some of the personal conflicts that come up in the conversation. Think about how you might respond to a person's question, and once the person has raised the conversation, how will you help them to walk through that, down the pathway to locate the best therapeutic response for them. So there's no presumption of competence, and the service cannot be provided to people who lack competence. A person's competence must be assessed as part of the process of accessing assisted dying. And this overrides right 7, which states that a person must be presumed competent unless there are reasonable grounds to believe that a person is not competent. So we've been talking about competence all the way through this presentation, and it's important to know that that this Act supports the informed decision that the person can make around receiving help for assisted dying.
So I'm just, it's always get lost in the legalese, but practically we all know that if we're giving informed consent in our general scope of practice, that we are obliged to offer all the options that might be available. So if we're referring a patient for care, we can't make the presumption they can't afford to go privately, so we make a referral to the hospital, but we are still obliged to say that the individual could use an insurance scheme or pay for it themselves if they felt that that was more appropriate. In this situation, the legislation actually obviates part of that conversation, because if you follow that logic, then you would be offering all options for end-of-life care. You would then be offering assisted dying as an option, but because the conversation has to be initiated by the patient, you can't offer that option until they raise it. So, practically we have to see how different that is. The same with competency. In every other circumstances, we have to presume competence, and unless we can disprove competence, then the patient's decision to do or take a course of action is supported. In this situation, you actually have to formally prove the competence. So again, it's quite a significant change from how we would approach our general patients in the population. Thanks.
Wow. Thank you. There's so much to think about, isn't there? So we're coming to the end of this now, and we're up to the part of almost to the part of administering the medication. So what happens at this step of the process? So in this step, Dr. Smith goes to Royal's home and is met by the family. He's in the bedroom along with several family members, and they're having a whanau time together. And Dr. Smith will run through the care plan with Kitty, the daughter, and checks if there have been any changes in the plan since the last time that they spoke. Dr. Smith reminds Kitty that she would like to speak to Royal alone, so Kitty arranges for the rest of the whanau to go. And this is a really important part of the step, so that Dr. Smith can check that the level of competence of Royal at that particular time, and check to see that this is still his informed choice and that he is competent to make that decision. So Dr. Smith runs through the options of the medication, and the option of delaying or stopping the process is also presented to him. Dr. Smith does a final check to make sure that all is good, and then she will set up the medical equipment for the administration of the medication. And Royal has chosen that Dr. Smith will administer the medication by IV. So all of these things have been thought about, they've been planned, and then they've been checked, and then established again with Royal that this is still the option that he chooses. So when Royal is ready, the doctor signals to the family to return, and then the family take care of the process. They have cutter care and the medication is administered, and Dr. Smith leaves the space and lets the family take care of what they want to do at that time. Royal dies, and then that's the end of that part of the process. So there is space given for the whānau clearly to do what they want to do with their family member, with Royal. And then we have to think about the aftercare in terms of administration reporting. So there is the completion of the clinical notes to do, and also needing to complete the death certificate. And at this point, we understand that on the death certificate, the cause of death can be written as the underlying health issue, which for Royal was lung cancer, and we need not write, needs not to be recorded on the death certificate that assisted death was the cause of death. This report is sent through to the registrar as soon as possible within 14 days.
So, Jemima, just really important, and this was a concern that I had about what would go on the death certificate.
Right.
So in engaging with consumers and with patients who might consider this, the strong opinion was that they did not want assisted dying to reflect. They didn't think it was appropriate for it to reflect on the death certificate. So doctor certifying the death would do no different than they did on any normal death certificate. But then there are additional forms that go with the process. So the assisted dying would be noted on the form that goes back to the registrar, and that form is visible to the funeral directors. So just important to recognize that it's patient-led co-design that has required that the assisted dying doesn't go on the death certificate. Thanks.
Thank you. I like that explanation. So there's the aftercare of the report writing, the aftercare of the patient, the aftercare of the family, and also the aftercare of the practitioner. So here we have the follow-up care of the Secretariat may follow up with the whānau to include there may be a referral for counselling or liaising with advocates or other people who've got a lived experience with this, with the delivery of this level of support, maybe liaising with community services and referrals to other services. So this slide is now wrapping up the aftercare of the family, and the doctor taking care of tidying up the IV cannula and the dressings, and any other waste that's connected with the activity. And then Dr. Smith reassures the family, extends an invitation to call for help, or if there is an expression of need that services can help them with. And then Dr. Smith drives home, where she completes the forms, the documentation, the tidy up of the medication, and the day after, she safely and securely returns the medication kit to the pharmacist. And the Secretariat's clinical advisor will get in touch with the family, as we mentioned earlier, just a couple of slides back.
So really, again, comes out quite clearly in the webinars that, you know, having a good support network as a provider of this service is really quite critical. In many countries, they've set up forums or communities of care with practitioners who are connected to each other so that they have a peer support network, have formal and informal collective meetings so they can debrief, that they have someone who they might reach out to ask some questions where they may be facing challenges that in the process and or with the eligibility, and also, you know, ensuring that they are looking after themselves in terms of self-care. As you've identified, you know, it's a complex process, not just one day. It's a journey that is undertaken, and there are going to be challenges along that journey. The doctor who did this in Canada suggested that he actually took the whole day off, and this wasn't just something that got fitted in amongst his daily appointment list, like popping out for a home visit or down to the local rest home. You know, the implications, the psychological import of being involved in this service is quite significant, and so he would choose not to work in his normal practice on that day and commit it to the patient and to his own self-care, and had some clear processes that he would undergo after the procedure had been completed that helped him deal with the emotions and intensity of the day. I mean, for many of us, particularly rural practitioners, taking the whole day away from the practice, you know, will be a big ask, and the financial remuneration may not equate to that period of lack of access, let alone not having access to us as practitioners for any other patients on that day. So there's quite a lot of thought and deliberation that needs to go into this, and you know, self-care is really critical and is probably broader than we might initially think, in terms of a simple, oh, I've got my self-care sorted, thanks. So again, some clear thinking early on, some strategic planning, and some secure steps to ensure that we have a pathway that keeps us healthy as well as meeting the demand, the choice that the patient has already made.
Great. Thank you, Graham, for those for sharing those examples, and I can absolutely support the invitation to everybody to have a look at the webinars and see the experience of those two doctors that Graham talks about. I think those are great examples. Thank you very much. So we came to the end of our presentation, and you'll see when you receive the slides, at the bottom of them are a list of resources. I turned the slides off so I could have a check and see what questions we had in the chat, and we don't have any at the moment. We have a comment that Graham responded to. Do you want to talk?
Yeah, so there's there's just one other, conundrum that I've come across in working through this, is that even if you don't make a conscientious objection for all your patients, and for example, if you've chosen to provide the service for your enrolled population only and not registered with scans, you, according to the clinical guidance that I've sought, that you can actually still choose to deliver the service to one member of your enrolled population because you've got a good relationship and it makes sense. But in another situation, you might declare a conscientious objection. And I think this is a very gray area and one that needs some careful thought process because, let alone equity in our broadest definition and focus on our priority populations, but equity to your population, it'd be quite a difficult conversation to say, I'm prepared to offer it to one person, but I actually conscientiously object to delivering it to someone else. So I think there are quite a lot of issues that are still going to have to be teased out and worked through in the day-to-day practical application of what is quite a structured legislation that doesn't necessarily address some of the subtle nuances of relationships and opportunities. Even if you do agree to deliver the service, there's still some gray areas that people are probably going to have to work through themselves, use the support structures that have been put in place so that when they feel a little bit lost in the process, then know that there are people to support them, but also have taken the time to think about maybe take themselves through a couple of user case examples, either in the learning or set up amongst themselves and their colleagues and have some conversation about what if this happens or what if that happens, how might I respond in this or that circumstance. And I think this is covered quite nicely in the education sessions as well. But this is not going to be an easy process for anyone, even if we're really clear on which side of the fence we sit in terms of the moral and ethical aspects of the legislation.
Thank you, Graham. Well, this has been a full conversation.
So, Jemima, there's a late question here about the implications for cremation and time to burial. That's a really interesting question. But I don't know that is necessarily affected if we have existing cultural or legislative processes that address that. The notification to the registrar is just another step, other than if we were to attend to a patient before the 7th of November. So the death certificate would be the same, the cremation certificate would be the same, as long as your documentation, as long as the registrar has signed off that the eligibility and the processes have been followed correctly. You can't proceed until they give you authority to proceed. So my gestalt is that will be no different than any other person. It's not going to be a sudden death. You know what the underlying condition is. You know what the cause of death is. And there should be no reason why you shouldn't proceed with a cremation if that is the individual's instruction as to how they want to be managed. In terms of cultural norms for Māoridom and tikanga, if that means that the person remains in the home for a period of time until the funeral directors are contacted. I can't see that. This is just another death, just the mechanism that's different. I don't know if that answers the question for you, Pops.
He's saying thanks. Thank you. Kia ora, Graham.
So the other thing I think it's probably quite important is then if you go on the learning page at the moment, there's a good overview and then there's more specific learnings. But if
Yes.
one was to actually be seriously considering getting involved in the service, then there are 5 more modules of training and then probable another 2 days of face-to-face, or they might have to find another way of delivering it with our current situation. But there was a 2-day face-to-face course supposed to have occurred early in October or late September. And, you can only access those additional modules if you register an interest, and you have to be a medical practitioner or a nurse practitioner, and you have to be identifiable by your council number to access that training. So it's not available, well, it shouldn't be available to anyone without a New Zealand Medical Council or New Zealand Nursing Council nurse practitioner registration number. Though I did hear someone had registered who may not fit that in. So I'm double checking that at the moment. But
Okay.
there's, clear formal training mechanism that is available, but it is controlled.
Yeah. Thank you, Graham.
Any other questions from the forum? You can shout out if you don't want to write it in the chat.
I think that might be us, so Graham.
Yeah, so the other thing that what we've recognized at the other education sessions, that people may feel that it's difficult to maybe ask a question in the open forum. And so, reach out to Jemima, myself, or Joe, and our emails are on the presentation, so that if you feel that you might want a more one-on-one conversation and that's you're more comfortable with that, we're more than happy to have those conversations in a more personal context. Thanks.
Cool. Thanks, Graham. And as everybody can see, you're probably going to be the most reliable clinical opinion that we've got in the team. So thank you so much for all of your support this evening. And thank Joe, who's not here, and the rest of the, us as a team for supporting what we've been doing. Thank you, Ropata, for joining in with us this evening. And so I'm going to pass the time back to you to close us up for this presentation. Thank you.
Tēnā Ropata, before you close, one of the things that we were hoping you might reflect on is the impact of tikanga. And one of the questions at a previous education session was, particularly in a small rural area where individuals who may be choosing to deliver the service may whakapapa to the individual who's requesting the service, or there are closer community connections. The question was asked from up in the far north on the peninsula, where small community, small group of people, and not a lot of practitioners available to offer the service. So it's one of the things that Jemima reflected on, and the need for a wānanga. We know that the ministry has engaged significant senior Māori leadership in trying to understand some of the impacts of tikanga on this, but we wondered if you had any thoughts in having listened this evening, or any guidance for us.
Yeah, kia ora, Graham. Also, Jemima. I think from just in general, whether it be culturally or non-culturally, it's quite a lot to take in, and hence the reason why my karakia was with rongo, because ultimately, the balance of life and death lies within our hands, and there are many stories within Te Ao Māori where you could say different tupuna or atua tried to conquer death. They tried to defeat the goddess of death itself, and in doing so, they died. And so having this option available takes us back to those times where man was challenging life and death. And that was not for medical purposes, or it was not for a cause that was going to, put them in a situation where eventually they were going to pass away naturally, or pass away in a lot of pain for some circumstances. Hence the reason for this act. This was done out of the pursuit to find eternal life and to be the holder of life and death. And so there's a saying within Te Ao Māori that, there's the word wairua. There's wai meaning water or flow, and rua meaning two. And the two is the life and the death. So we have a wairua, we all have a wairua within us. You choose to nourish either of those two wai. Sometimes we don't have an option, like with, some medical conditions. It's not something that they chose to take on themselves, some of these conditions that our whānau have, pretty unlucky. And so having this option, to end the suffering and end the pain, it goes back to those stories of being the holders of life and death, and honouring the wairua within you, and the two wai, the life and the death that we have within us, and the mauri that we have within us. But having this option available to us now, I think, has never ever been a whakaaro or an idea that we have talked about within Te Ao Māori, because we honour and we strive to live, and we pursue life, and everything that we uphold within Te Ao Māori is to do with life. And of course, with there's an opposite to that, which is death. So there's a saying that our wairua, when we are born into this world, we have the wairua. There's the two wairua. There's the two wai. One, the vessel, our tinana. We have the authority to control our body and what we do with our body, and with our waka, our vessel, we have total control over. Whether you have medical conditions or not, we have total control over our body and what we do with our body in this world. The other side is the wairua, our spirit. Our spirit, we do not have control over. Our creator, Io, and our tupuna, ultimately they play some sort of part in the spiritual world in Te Ao Wairua. So having this option available to us and having these kind of kōrero with our whānau is something very, very foreign and something very new, but it isn't at the same time. It goes back to those stories of Maui who tried to defeat Hine Nui Te Pō, who was the goddess of death, and in doing so, he was unsuccessful, and he got taken and he moved on to the spiritual world. But also with Tāne creating life and giving mankind, or giving tangata, us as human beings, the option to have life and death. And of course, Maui, who was a human being, tried to cheat that. But this is all sort of culturally in a Te Ao Māori, being culturally aware of this is a very new whakaaro. It's a very new whakaaro, but it's also, I think, in some ways, for whānau that are not well, and we see whānau that do suffer, a nicer option for them to not have to suffer anymore, because within our tangihanga, within our whai kōrero and our oratory and our farewells, our poroporo aki, we mention these things to those that have passed on. We say things like, you do not have to suffer. Now you are able, even though you have passed on, you have gained life again within Te Ao Wairua. You do not have to suffer the pain of being here in the physical world. And this usually pertains to someone that had suffered from medical conditions. So, that changes the whole whai kōrero farewell poroaki process as well, because now they don't have to suffer. Now they can choose to go peacefully and without any pain, without any suffering. So, having our wānanga with our whānau and talking about this option, I think is there should be some urgency around this before the bill passes and before it comes into play. So our whānau are aware of the options, and also, we can be quite greedy and selfish sometimes, and we want nan and we want our papa to stay. We want to hold on to them. We want to keep them close to us, even though they may be suffering physically. So I think this has been a great hui. It's been a great insight for me personally, because my father has suffered, I could say, about 10 or 12 heart attacks over my lifetime. And recently, we nearly lost him beginning of this year. He stopped breathing. He did die for 12 minutes. And then he was resuscitated and he was brought back to life again. But when he came back, he's still not fully here. He's got 1 foot in the door of Te Ao Wairua and 1 foot in Te Ao Marama, 1 foot here in the physical world. During that time, that 12 minutes, he realized that the balance of life and death lies within our hands, and that he passed over for a short amount of time. And the experience that he had was very overwhelming and very enlightening and very, his words, very beautiful. And for whānau, that can be hard to understand and hard to accept, that, people that we love that are suffering, through their conditions, may actually want to be better and may want to be at peace with themselves and take this option. But that's just an assumption as well. So that's something that we need to wānanga as iwi, as whānau, as hapu, and I think also as health practitioners as well, as professionals, to have that kōrero. It's kind of I don't think it's a grey area. I think it's just, it can be quite overwhelming to know that you have the option, and you know that you have that mana, or that rangatiratanga, the authority to choose that side. And this case here, for those that are suffering and those that are going through pain and mamai and their conditions that they're in. So I just want to thank you all for this hui, this kōrero tonight, and also all the mahi involved and all the research involved, both Hemaima, Graham, and also those that attended the hui today. Definitely going to have more wānanga about this, and this is something that I have been thinking about for a long time as well, because of my father, and because he talks about te ao wairua all the time. He talks about who he saw, who was there at the door, and the work that he has done, and that the legacy that he has left behind. He feels like he wants to walk through the door pretty much, and it's hard to fathom. It's hard to comprehend someone who's able to decide whether they stay or go. But ultimately, that's up to them. That's their choice, and that's their rangatiratanga. That's their authority to do so. And going back to our atua and te ao Māori, that was the choice, and that was the option that Tāne gave to us when he created tangata, and he instilled the wairua within us. So the wānanga needs to go back to then, back to those times of our tūpuna, back to the atua and those stories of creation, and also brought into modern day context and about the option available, and also the reasons why whānau may choose this option. So thank you, Graham. Thank you, Hemaima. Thank you, everyone.
Kia ora rōpata. Before you offer that karakia, I want to sing us a waiata.
Ka pai.
Because we do need to celebrate the life, and tonight we probably need to acknowledge our awareness of the value of life. And so, he kore au, he ngaro, e ruirui a mai I rangi ātea. Our life all began in the same place, and we will all go back to the same place, and all of this kōrero that we've had tonight, it matters. So, he kore au, he ngaro, he kakano, I ruirui a mai, I rangi ātea. Me mihi atu kia koe rōpata, mō tō kōrero, mō tō āwhina, I a mātou I tēnei pō, ki te kōrero, ki te kaupapa I tēnei wā.
Kia ora.
Tēnā koe, tēnā koutou katoa. He karakia?
Ai, karakia. Ka pai. E mihi ana kia koutou I tēnei wā. O tira, ka tira e ngā tūpuna, e ngā atua, kia whakatata mai rā kia mātou I tēnei pō. Kia whakawātea e nei kōrero, kia whakamahia e nei wānanga, kia noa, Kia kore e pā mai he wairua kino ki runga i a mātou. Engari kia whai māramatanga ki ēnei kōrero, kia whai māramatanga ki ēnei tapu, kia whai māramatanga ki ēnei mauri, e kōrero nei mātou. Arahina mātou i roto i a mātou mahi katoa. O tira kia taura ngā manaakitanga ki runga i o mātou whānau, ngā whānau e māwiwi ana, ngā whānau e pōhara ana, me ngā whānau e moke moke e pauri ana. O atu ki a rātou te aroha, te manaakitanga, me te wairua tapu o ngā mātua tūpuna. Kia turuturu ōwhiti, kia whakamaua mai kia tīnā, tīnā. Hara mai te toki, tau mai te mauri, ho haumi e hui e, tai ki e. Kia ora tātou. Kia ora.
Tēnā koutou.
Thanks, Helen, for supporting us, and have a good evening.
Yeah, thank
Thank you,
Helen.
everybody.
Thank you.
Good night.
Thank you. Bye.